Okay, so in this video, we're going to talk about the leg, knee, and ankle. First, if you have a meniscal tear, you're going to have a small effusion around the knee, and patients will also complain of a locking sensation when they walk. Next, we have an ACL tear, which is very common. You'll have that popping sound, you'll have a large effusion that forms around the knee, and the patients will feel very unstable when they try to put any weight on that knee. For any ligament or meniscal tears, you want to do an MRI to diagnose it. For an MCL tear, that's instability with lateral movement. So if this is my knee and I have a force coming in from the outside, that's going to cause pain with the medial cruciate ligament over here. It's also known as valgus laxity. On contrast, with an LCL tear, they'll have instability with medial movement or varus laxity. So this is my knee and I'm coming in from the inside of it. That's going to cause issues with the LCL over here. Next, we have genu valgum and genu varum. This is like a very common thing that can happen in kids, so you can just reassure they should grow out of it. So genu varum is normal from birth until age 2, and this is described as like bow-leggedness. Genu valgum is when they're knock-kneed, and that's common from ages 2 to 5, and they should grow out of it by age 7. Patellofemoral pain syndrome is the most common cause of knee pain, especially in young females. It's worse when they're like going up and down stairs, or if they get up after sitting for a long period of time. Squatting and running can also make it hurt. You diagnose it by doing a patellofemoral compression test. So when their knee is extended, you can compress the patella and that will cause pain. And for treatment, you tell them to strengthen their quads. Osgood Schlatter is when you have tenderness of the tibial tubercle, common in kids when they're growing up and playing a lot of sports, especially ones that involve jumping, such as volleyball or basketball. A Pes Anserine Bursitis can develop on the medial side of the knee and cause pain there. Some risk factors for that is obesity or having diabetes, osteoarthritis of the knee. A prepatellar bursitis is also called a housemaid's knee. It's common in people whose jobs involve a lot of kneeling, and sometimes that bursa can get infected, most commonly by Staph aureus, and then cause a septic arthritis. If that happens, you can aspirate the bursa and give them antibiotics. So a prepatellar will be on the front of the knee. Behind the knee is called a popliteal cyst or a Baker's cyst, and that'll cause pain behind their knee. And next we have patellar and quadriceps tendon tear. So this is my knee. This will be my quadriceps tendon, and this will be the patellar tendon, keeping the patella or the kneecap in place. If you have a quadriceps tendon tear, then it's only the patellar tendon that's holding onto the kneecap, which will cause an inferior displacement of the patella. Now, if you have a patellar tendon tear, then only the quadriceps hanging onto it, and that'll cause a superior displacement of the patella. And taking fluoroquinolones is always a big risk factor for a tendon tear. Now, talking about some nerves that affect the leg and the knee. First, we have the femoral nerve. This allows you to extend your knee. It's also responsible for the knee reflex. The femoral nerve also provides sensation over the anterior medial aspects of the thigh. Your lateral femoral nerve will innervate and give sensation to the lateral side of your thigh. And if you lose sensation there, there's a syndrome called myalgia paresthetica. So if you are obese or wear tight clothing, that can cause compression of the nerve and cause those symptoms. Your obturator nerve is responsible for adduction of your leg and medial thigh sensation. Your sciatic nerve innervates your lower leg, but it does not innervate your medial calf in your foot. Sciatic nerve splits into the common peroneal nerve and your tibial nerve. So the common peroneal nerve is also known as the fibular nerve, and that's responsible for dorsiflexion, so toes to the ceiling. If you lose common peroneal nerve function, you're not going to be able to pick your feet up, so they're going to have a foot drop, so they'll stomp more. And then the tibial nerve is the opposite. It helps you do plantar flexion, so toes to the ground. So if that nerve is affected, they won't be able to like walk on their toes. There's Tarsal Tunnel Syndrome, which is the same thing as carpal tunnel except in your foot. So carpal tunnel is your median nerve like in your wrist, and then tarsal tunnel is a compression of the tibial nerve in your foot, and that'll also cause like numbness, tingling, burning. And to diagnose both of the carpal and tunnel syndrome, you can do a nerve conduction study. Moving on to your ankle, you can have Achilles tendon rupture, and to diagnose that, you can do a Thompson test. This is when you squeeze the calf muscle and then the foot should plantar flex. If it doesn't do that, then that's a positive finding and you most likely have an Achilles tendon rupture. There's an Ottawa Rule that helps you figure out if you need to take an x-ray of the foot or the ankle. If you have an ankle injury and then on physical exam you have a tenderness along the posterior edge of the lateral or medial malleolus and you can't put any weight on it, then you have to get an x-ray. The anterior talofibular ligament is the most commonly injured ligament in the ankle. It's a clinical diagnosis. It's the most likely thing that you sprained, so you don't need to do any imaging, but if your symptoms don't improve in about 2 months or so, you should get an MRI. Calcaneal apophysitis is also known as Sever's disease. It's common in kids that are very active. You can diagnose this by squeezing their calcaneal bone in their foot, and that'll reproduce the pain. You should limit their activity for a little while and then give them NSAIDs for pain relief. Plantar fasciitis is inflammation of the plantar aponeurosis. You can reproduce the pain by passively dorsiflexing the toes. Patients will often complain about the pain being the worst when they first get out of bed and take their first few steps. For treatment, there's unfortunately not much you can do. Physical therapy or inserting padded heel pads into their shoes would help. Now for stress fracture and shin splints. So stress fracture, you're going to have localized point tenderness pain, and shin splints, you're going to have a diffuse area of tenderness. To get a stress fracture, patients usually will have an increased level of activity recently, also having that triad of oligomenorrhea, osteoporosis, and decreased calorie intake can put you more at risk as well. For a stress fracture, you can do imaging, but the x-ray won't really show anything, at least for first month or two. Then for shin splint, it's very common in runners. They'll get a medial tibial stress syndrome, so they'll get anterior leg pain. Lastly, we have Duchenne Muscular Dystrophy. This is an X-linked recessive disorder. The patients will present with a Gower sign. Their legs are very weak, so they use their upper body to help them stand up. They'll have calf pseudohypertrophy, so the muscle in their calf is replaced by fat. Patients can also present with scoliosis and dilated cardiomyopathy, and their CK levels will also be elevated on labs. And then Becker's syndrome is a milder version of Duchenne's.